is obviously interstitial cystitis versus chronic UTI and other procedures. So IC exists in 1 to 5 out of every 1,000 patients. How do you determine the 1 to 5?
I think that IC has to be you've got to start with IC all over again, right from the very beginning. Because the point is that the diagnostic, this is what happens. In fact, I've just recorded a lecture for the UKCS that's online that is addressing just this. I hope they make it public. But when you come into your doctor and you may or may not have your history and you're examined. Now that history and examination is incredibly important in establishing the probabilities that exist. The next thing is they move on to do a urine test. Now, if you've got the symptoms and physical signs of a urine infection, the laws of probability are such that if that test comes back negative, it is probably, most probably a false negative. Understand?
Yeah.
So there's a massive mistake being made, which is called ignoring the base rate, where you come in with all the right symptoms, they do a test and they say, well, you can't have an infection, the test is negative. Wrong. The test is probably a false negative. That's the point. Now, IC was invented to explain those with symptoms and a negative test.
Yeah.
And there's no two ways about it. That is exactly where it grew up. Now, so let's look at the test. So we've scrutinized the test every which way and how, using a system called consilience. Now, consilience is where you take a problem and you surround it with all sorts of ways of scrutinizing it. So you look at it above, below, underneath, inside the lot. And we did that with the test and eventually came to the conclusion this test is lying. There's no two ways. It's so wrong, it's lying. So not only have you got the problem of the base rate fallacy by not considering the history and physical examination, you're then using a test that's lying to wipe it out. Now that is the foundation of interstitial cystitis. So just from a scientific point of view, we have no other alternative but to go back and re-scrutinize it. Now, we're about to, I think Sheila's the one that's going to publish the data. We get referred a huge number of patients with a diagnosis of interstitial cystitis. And with tiny number of exceptions, we find that there's a urine infection there. So we have to be extremely skeptical about interstitial cystitis. Now, the other point is that the histology of interstitial cystitis is identical to the histology of a chronic cystitis. There is no difference. Secondly, that in any inflammatory reaction, you will have mast cells present. And for some reason, I don't understand it, people jumped on the fact that they'd seen mast cells in interstitial cystitis and started making a big deal about it. I just baffled by it. The mast cells need to be there because they trigger the shedding of the epithelial cells in a urine infection, so they're bound to be present. And then there are all these other theories about loss of gaglia and so on. And there again, the gaglia, it sounds terribly impressive. Glycosaminoglycan lab. And you see, once you start using complicated words, everyone thinks, oh, gee, God, no. Right, now another word for glycosaminoglycan, is mucopolysaccharide. And another word for mucopolysaccharide is snot. All right. So if you look at it, all your tubes, your intestines, your bladder, your windpipes, your sinuses, they're covered in mucopolysaccharide. Yeah. And it's a gooey mucopolysaccharide, and probably the biggest source of our mucopolysaccharides are the microbes living on the surface of our epithelia, forming their biofilms. So this gag layer thing, if you look at it, it's got, on top of that, when they did electron microscopy and advanced microscopy studies, they found that the gag layer wasn't missing. I don't think it should be missing. So it's somehow got into the mythology of the interstitial cystitis, and it's grown. Now, once again, it's grown with all these accretions, and these rituals have arisen, and it's going to be very difficult to dig it out. Now, Richard Feynman, the theoretical physicist, gave a lecture at the California Institute of Technology in '76, where he described this thing as cargo cult science. Now, during the 1941 to 45 war, in the islands of the South Pacific, the American logistics corps were flying in supplies for the forces fighting the Japanese. And Melanese tribal folk saw this happening on their islands. So you had these cargo planes coming in onto the landing strips and offloading vast amounts of food and transport and all sorts of bountiful things. And they were amazed. And they developed amongst themselves religious beliefs that said that these bountiful, these ships full of bounty were being sent to them by the gods. And what was happening was that these foreigners were usurping what was meant for them by building these landing strips and various bits.
Yep.
So they went back into their villages on the hills and in the jungles, and they modeled planes, runways, goggles, earphones, watchtowers, landing lights, the lot. And the principle was that if they recreated this, what the foreigners were recreating, then the gods' messengers would come and land where they ought to and offload their bounty for them. Now, Richard Feynman made the point of cargo cult science is this. It's where people go through the rituals of science in the expectation that the answer will come out of it. And so doing DNA analysis of the urine is going through the rituals of science, isn't it? It looks great. Dipping the urine with a dipstick and it comes out with all sorts of different colors is doing science. It's colorimetric science and so on. And infusing heparin into the bladder, because heparin molecules are in fact found in snot, oddly enough. So if we put the heparin in, no doubt the snot will take it up and build more snot and so on. This is all cargo cult science. And in his lecture, Richard Feynman said, but of course, you want me to answer the question, what's missing? Why doesn't it work? And he said, well, it's the absence of that strict honesty. It's almost like a bending over backwards honesty that is scrupulous and critical in the way that it scrutinizes your data, how you set about it, how you collected it, what your hypotheses were, and really thinks it through with a terrible honesty. Now, the thing is, I could come up with some test and decide, okay, I'm going to promote this as a test for cystitis. And I could do some tests that showed that there were differences between patients and controls. And I could then start promoting it. And if people started challenging me, I just argue back at them. using rhetoric, sophistry, and so on and so forth. But at no stage am I being honest. Am I saying, actually, what is this really telling me? And I think that's the problem. And so you've got all this sort of cargo cult science that involves bladder installations, stretching the urethra, stretching the bladder, using Elmiron, and so on. All of these, if you trace those back, they all start with exactly the same principle of what those Milanese villagers are doing. All right. It really, what it is a conjecture becomes a wish, and then that wish becomes a hope, and then the hope becomes an expectation. And I suppose the other thing is, remember, is always follow the money. Okay. Yeah. So that you're going to see that always the reason that we've got such strict rules about conflicts of interest in our unit, such strict rules, it's simply because of that huge danger of finding yourself following the money. All right. So that we're trying to all the time remove any kind of personal financial interest in the things that we're doing. So in fact, that what we'll do is deliberately screw a patent by, you'll understand patent law, but by writing it up and sabotaging it, so that there's no risk of us getting stuck in that position. Because once you're like that, it's terrible.
So patients that undergo the IC-related procedures, such as urethral dilations and hydrodistension, do you find that they're more difficult to treat when they're under chronic UTI treatment?
Not that we've noticed.
No.
No, and there's one exception to that, is that some people who've had a urethral dilatation have incontinence. So the urethra's been damaged and they got incontinence. It's certainly, if someone's under our care and they start, well, we had an incident about a year ago where someone quite innocently went and got a assisted distension because a urologist said she had to have it. We discharged her immediately. And that's what we'll do, is that it just clicks in. That if someone duplicately cares whether they're innocent or not, we just discharge them on the spot, and then they got to renegotiate coming back to us. But that makes sure that there's no danger of, to the best of our ability, that there's no danger of duplicate treating. Though I am aware that there are patients who are stupidly duplicately treating, but there's not, if they can conceal it from us, there's nothing that we can do about it. But if we find out and they were concealing it, then they would never get back into our unit again, ever. It's a very dangerous thing to do.
It is a very dangerous thing to do, and it just sort of risks the clinic for every other patient then, actually. So it's quite a selfish thing to do.
Does an embedded UTI cause longer term nerve damage within the bladder that requires additional treatment?
Well, certainly chronic inflammation of any kind is known to induce neuropathic pains anywhere in the body. So we do have to treat neuropathic pain. We do that with amitriptyline and then pregabalin. Pregabalin is now a group 3 controlled drug, so it's got to be done on a special NHS prescription. And I've elected that we're not going to run those, we're not going to prescribe it, so we'll hand it to the GP.
Okay.
But the neuropathic pain is extremely variable in who it afflicts. So we can get some people with a very short history and they've got terrible neuropathic pain. And I've got others who've got, dreadful bladders. I mean, they're chronic sepsis bladder, no neuropathic pain whatsoever, chirpy as hell. So that there isn't a strong relationship between the two, no. But most of it can be dealt with using amitriptyline or dothiapine or pregabalin. Yeah.
Okay.
And the secret to that is clearly remove the cause. So a big concentration on getting the cause away. And I think a lot of distress has been caused by the fact that the urine clears and then some of the symptoms clear, and then this persistent pain hangs there, and people get very, very upset about it and worried that it's not going to be all right. It's part of the story. It's okay. It's okay.
Yeah. Yeah. Thank you. The next part is, does the length of time that somebody has had the infection or suffered dictate in how long it will take to treat?
I answered that question during the year. We collected a whole lot of data on length of time, and no, zero relationship. All right.
Yeah.
None at all.
Have you ever run out of antibiotics to work for those hard to treat, difficult cases?
Not yet.
Thank you.
They all get referred up to me by the gang, and I mean, clearly that they're sort of they give me a roller coaster ride.
Yeah.
White knuckle ride. Yeah.
Yeah.
Yeah. I'm able to tell at the moment I haven't yet.
Good. Okay.
Been stumped by it. Haven't yet. It's most extraordinary.
Yeah, I mean, it's something that we have a lot of on the group, isn't it, Michelle? A lot of comments where people get, you know, really worried, and they think that they're going to run out of antibiotics.
No, just not.
So,
and listen, I think it's 7,500 patients have been through my hands, and I haven't been stumped yet.
Yeah.
All right. I can understand why, because if you look at the mathematics of it, you're dealing the combinatorial. You've got a combinatorial explosion of options there, so you're not going to really run out of options. And usually we find some way of getting it in under the guard of the side effects.
Yeah.
I think that would be really reassuring to people, because I think that is something that really does frighten people, that they will just run out of options there.
No, it's not happened yet.
And that's good. That's really reassuring.
It's Michelle now, isn't it, for your little section?
Yeah, so we wanted to ask about connections with any kind of crossovers with other conditions that you might have noticed, because it's something anecdotally we've seen on the group. So crossovers, for example, between conditions like endometriosis and fibromyalgia, and whether you've seen or observed that in your practice.
No, the difficulty with this is you will get the you're bound to get coincidences cropping up quite frequently, because these are relatively common conditions. But the very closest we might get to it is the fact that Reiter's disease involves the urethritis and arthritis, and then that forms these sacroiliitis, ankylosing spondylitis, psoriasis, psoriatic arthropathy, group inflammatory bowel disease, and what have you. So that we will have had our beady eyes out for some kind of link there for years and years and years and seen nothing.
Right.
And I don't think there are any linked diseases at all. People's arthritis get worse because of our you know, they get joint pains from our treatment, but that's as close as we've ever got to it. So I don't think there is any link, no.
That's really interesting. What about the immune deficient patients then? So say if you had a patient, for example, with HIV, would you find it?
Yeah, well, in fact, that's the first time I diagnosed someone with HIV was he was coming to see me because he had a urine infection and was not responding in the way what I would expect. So I did a HIV test and he had HIV. The HIV people who are under treatment properly, there's no problem whatsoever. There's no difficulty. And as to the other immune diseases, we don't have a problem. Right, we just don't see a problem. So I don't think that a lot of people go, no, I'm immune. Some people say that they have problems with their immunity. Well, I don't know where they get that idea from. I'd like to introduce them to somebody with a true immune disease, and then they'll wake up, because the autoimmune diseases are horrible. So you know, there's a lot of in the quack world. Oh, your immunity. It's a sort of your immunity and your yeasts.
One last question from me, and then back to Joanne on those who can't tolerate the oral antibiotics. But my question is, Do you think there is some kind of genetic component? Because for me, I seem to be the anomaly in my family. I don't know a single other person who's ever had a UTI.
I don't think. I think it's incredibly weak. Incredibly. I've got a very small number where it's the grandmother, the mother, and the daughter, and whatever. But it's desperately weak. So, and frankly, if you look at the microbiome, the probability is of a random delinquent bug is far greater than a genetic predisposition. And I think that's quite important, because you know that people go on an awful lot about receptor function and binding of bacteria and so on. Well, you know, that will depend upon genetic influences, and if we're not seeing genetic phenotypes that suggest there is a genetic link, then you know, let's be cautious. I don't think it is a familial disease at all.
Good. Over to you, Joanne, for the group that can't tolerate antibiotics.
Yeah, we do have quite a few. I might have to narrow some of these down, so I'll pick out some that I feel is most important. So those that cannot tolerate antibiotics. So how do you treat patients?
Well, we got some people where we've elected to just try and work them through using Hiprex on its own.
Yeah.
And frankly, it's working quite successfully. They've just got to be so patient. But the biological markers are coming on, and their symptoms haven't changed at all, but they're coming on, so we're sticking at it. And in essence, Hiprex is a very, very good drug. It's jolly slow, but it's a really good drug. And apart from indigestion and burning when you pee, it doesn't cause any other side effects. So, you know, when you've got the other side effects with other antibiotics, Hiprex is not comparable to that. The other thing is we quite often revisit old antibiotics that caused troubles in the past, but don't. And we can all sort of shuffle the changes. The tetracycline's a classic, as we run through all sorts of different tetracyclines, and usually get one. You know, I've got people who can't take limacycline, they can't take doxycycline, can't take minocycline. They're happy as Larry on oxytetracycline.
Yeah.
So you do quite a lot of that, all right? And I think that people must, you know, learn not to catastrophize about it. We got many options, but they've got to understand that we're not going to run through those options in quick fire. We're going to go really slowly, really conservatively, and they just have to be patient.
Yeah, I can understand that.
I got a woman who was in contact today in America, so she's absolutely fabulous on furodantin, the original crude nitrofurantoin that makes everybody else sick. So
I mean, it does make perfect sense. I mean, for example, for me, I can't touch doxycycline. I touch one pill of doxycycline and I'm horrifically nauseous. I can take 4 limecycline a day. Fabulous.
So it's often that. And I think people have got to stop this business of thinking of sort of prophesying doom. It's very unlikely to happen.
Yeah,
absolutely.
The next section is yeast infections and gut problems. So lots and lots of people seem to get a lot of yeast infections.
Well, no, hang on, wait. I'm very skeptical about this, because they're going to these shit merchants that sort of take pieces off you and start. So it's a bit like the first scene of Macbeth, you know, woolly, the bit of frog's leg and this, that, and stew. And they come up with these absolute crackball things about yeasts. For love of God, fungi make the world go round, all right? They're incredibly important elements. And yeasts are bound to be incredibly important in our gut. So the fact that these woo-woo merchants are finding yeasts, well, I should damn well hope so. And it troubles me that these sort of nutritionists and so on, and I don't know, that whatever it is, go on about. I got people turning up and they say, "Oh, I'm covered in yeast." No, you're not. You're not. All right. The point about yeast infections of any significance is they're a function of immune deficiency. So in the old days of AIDS and so on, I could have shown you people with yeast infections, right? But most of the time they're not a problem other than vaginal candidal infections.
Yeah.
But we've learned something big with that. We've learned that probably the worst way of managing those is with antifungal agents, fungicides, because all you do is clear it, stop it, back it comes again, clear it, stop it. So we're now emphasizing this business of the very conscientious principles of acidifying the vagina, using any of the acidifying agents that suit you. We recommend boric acid, but whatever, and sticking at that. And that's Darwinian biology. That keeps that keeps the candida out the system, because it can't function in that kind of environment. As to yeasts in the gut, leave the poor buggers alone. All right, they're doing a great job. And think, like for instance, you know the trees in your garden. The trees in your garden could not live if they weren't infected with fungi, and the fungi, their roots are infected with fungi, and the hyphae of the fungi feed the tree. All right, so the people, if some wacko sort of snake oil merchant starts going about yeasts, block your ears. All right.
You brought us excellently onto the next section, which was alternative therapies, aka quackeries. We've asked you for this position before and asked you your thoughts on this before, but I'm going to ask you again on this video so people can really see you say this. What are your thoughts about alternative natural treatments for chronic UTI, things like biofilm busters?
The thing is that these have all been looked at using science, and they're useless. Now let me explain something to you. That I could make a fortune out of this, absolute fortune. And what I'd play on is the Micawberism. That it comes from Dickens' character in David Copperfield, Mr. Micawber. Something will turn up, and so people end up in this situation. Well, I might as well try it because it can't do any harm. Yeah, and they're being fleeced. Because what I do is create my quack remedy. Might as well try it. Something might turn up. Doesn't work. It's all right. Next year we bring out the next quack remedy. And what we'll do is just rename the original one, but we'll say ultra or enhanced or new improved. Right. And so people say, well, I'll give that a try. Yeah. And so you go on cycling through the whole process. So you just keep on selling. It never stops. And it's very difficult to dissuade people, because a wish becomes a hope. That's the point. And I liken it is that, we don't like it at all when we're scammed. These somehow. The other day, I almost lapsed into a scam. Someone sent me an incredibly skillful email, and with my brain half in neutral, I started pursuing it. And then suddenly I thought, hang on, wait a minute, this guy's so I looked it up, and it was a load of old bollocks. But even though I wasn't I was resenting it all day. It really got me that I've been caught out. All right. So it's quite tough for people to say, actually, I've been scammed by this herbal remedy. But if any of these worked, we would be using them. Because understand this, when I brought Hiprex back from retirement, our unit was scoffed at and derided because we were introducing a quack remedy. as it were. So we're quite willing to look at what looks like a natural or quack remedy if there's some good science and we can provide some evidence. But a lot of these things, it's absolutely outrageous, simply outrageous.
Do you think there's anything out there that does stand up to scrutiny? That does?
Well, I think in the first chapter of the book, I cover this, that I thought that, you know, with the monastic traditions of the Middle Ages and the networks that existed through the Benedictine orders and the infirmarians, I felt quite sure that there was some sort of wisdom that would have been extracted by a process of trial and error elimination, with the enhanced by the communication between infirmarians all over Europe and so on. And so I was really interested when I discovered these academics who spent a long time scrutinizing the folk remedies in the United Kingdom and Ireland. And I was really amazed that there was nothing. And people often say, oh, well, there was the foxglove, digitalis. Well, frankly, I'm not sure that digitalis does it much good anyway in that case. And it just doesn't come out. So, and on top of that, I mean, if you go back to the original Galen, that his unfortunately so much of his writings got lost in the transcribing during the Middle Ages and in the Muslim empires, Islamic empires, that a lot of his wisdom was lost. But the fragments suggest that he emphasized hygiene, cleanliness, nutrition, and rest. And in fact, that's what that's what the infirmarians were doing in the monasteries, and the herbs were used as a kind of nutritional supplement. So it is wrong for people to think that herbal medicine has not been scrutinized extremely thoroughly. Right? Those of us who are all the Darwinian scientists, of which there are people who strongly believe in Darwin, would say there's something's bound to have come out of it. Right? So we've looked at it and it didn't. So my view is that you want to save your money and avoid this business of thinking, well, I might as well try it because it doesn't do any harm, because in fact it does do you harm. Because it induces in you a sort of sense of hope that's misplaced.
Indeed. Indeed, and I think that's what I find quite horrifying sometimes when I'm reading through some of the posts on the group and you see the number of supplements people are taking. You know, they're taking 15 different supplements. And I just can't. In the book,
I described my altercation with those quack snake oil merchants at a conference, isn't it? And what I found chilling was their cold indifference to the plight of the patients. It was honestly like talking to a concentration camp guard. It was horrifying. And I think people need to be aware of that.
I agree, 100%. 100%.
It covers quite a lot of that in the book.
Yeah, absolutely. We don't have that many more, so I'm sorry we've kept you for so long. We just cover a few more sections, if that's okay.
Fulguration, I think, isn't it?
Yeah, we've got to cover the fulguration thing because it's come up again and again and again recently. So somebody has asked, I have inflammation in my trigone. Will this eventually go away with long-term antibiotics, or do I need to undergo a fulguration?
Now, fulguration, first of all, there's not a gnat's bit of evidence that fulguration fulfills any therapeutic role at all. Zero. The worst thing about fulguration is you can't see it happening. Right? What I tell you can see is if you take a branding iron and put it on your arm, all right, burn your skin and then look at it, and you'll discover that you're scarred for life.
Yeah.
If you burn tissue, it becomes scarred, but you can't see it. Right? So to use burning in the treatment of anything, you are required to have incredibly good reason for doing it and good evidence. Now, the fulguration cisterns develop for burning polyps in the bladder and tumours. Absolutely appropriate. There's a long history of evidence. It works. But it's a pinpoint. It's a point. You know, the papilloma's on a stalk, so you're burning a stalk. Remember that the bladder is also polymicrobial. If you the one thing that haunts us on a burns unit is infection.
Yes.
Right. So if you burn the tissue, you create it solidifies the tissue. You then you're creating what is effective as an ulcer, and you've destroyed the first defenses mechanisms, and it's in a bacterial environment. You have no idea what's happening. All right. I was horrified when I heard that this was happening, because I would liken it to if you got acne, why don't you just burn it with a soldering iron, right? Because it strikes me as not much different. So unless someone can come forward with some scientific justification for doing this, and there isn't any, then I think it's incredible questionable thing to do.
Yeah. Thank you for clarifying that again, because that obviously, because of recent events, that's come up quite a lot on the group. So it's again good to have a really clear.
Well, I'll tell you something. I was absolutely shocked to hear that this was happening. All right. And
So
what they are burning is this metaplasia. And for years I've been pleading with urologists to come and cooperate with us in the study of what that metaplasia is really about, because we're dependent upon them to get brush samples out of it. But we just can't organize them into doing that.
There you go.
So we're hopefully with the urogynecologists coming into our unit now, we're going to be able to organize that. But the point is that metaplasia on the trigon has never been properly studied. Right. So you've got to screw. It's incredibly important, because there's a chance that it might be part of the innate immune response. You know, burn it. Right.
See, I find all this quite baffling, because at the moment I'm undergoing this battle with the NHS website to try and get them to acknowledge the fact that in some IC patients, antibiotics are helpful.
Yeah.
And I'm hearing about how all of these different treatments have been developed and how they've just sort of suddenly appeared in medical science without there being any sort of proper justification.
That is the baffling. That is what is. Yeah.
And yet I get that resistance back from the NHS web team saying to me, well, of course we can't put this on the web page because there's no justificatory evidence. So it's just
what it boils down to is this RCT business.
Yes.
So the RCT has become the holy grail. But the trouble is, a lot of these RCTs are a load of old junk. Yeah, I could do you an RCT that give you the answer you wanted, provided you were willing to pay me enough.
Yeah.
And I give you the p-values, and you could send it up and get you. And until people, the evidence-based medicine movement wakes up, grows up, and starts going back to the original empirical science of people like, you know, a wonderful contemporary example is Richard Feynman. Another Richard Dawkins, who's a bit of a, you know, he's a controversial character, but and you know, Pasteur, and what was it? Actually, this is the trouble. I can't say. Karl Popper.
Yes.
All these characters, incredibly important. Actually, I list a whole lot of them in the book, I think.
Yeah, you do.
Science.
You do.
But the RCT is I mean, there's no doubt about it. Done properly, an RCT is an incredibly valuable tool. But when we were doing, Jenny and I were working on RCTs together, we both of us started to develop huge doubts about the quality of some of the stuff that was being done, and the results that were being dug out of them. It's very, very disturbing. All right.
Okay, thank you for answering that. A question from me, and then handing over to Joanne. Just a couple of things. Is there anything that can be done for frequency and urgency whilst antibiotics are taking effect?
Well, there's evidence that the antimuscarinic agents are helpful. So detrusitol, I was on the the development team for detrusitol. So oxybutynin, I was also involved in clinical trials of oxybutynin. Solifenicin's a bit powerful, gives you a bit of a dry mouth. Those things are worth. And maribegron.
Okay.
So we are using overactive bladder treatments while we got the patients on active treatment. But I can tell you, once you clear the infection, the overactive bladder is so easy to treat with those drugs.